is there any way you can differentiate between, I know this is a different topic, but between an MI and Takotsubo? That's a very exotic topic. All right, Takotsubo. Is there any way to differentiate between the two of them on EKG? Like the aspect of the Q wave, of the fact that one may have ST elevation and the other one doesn't, or one has T wave inversion and the other one doesn't. Is there any way to differentiate, saying that, oh, this guy has this doesn't have this? Not really.
Takotsubo is like diagnosis exclusion. Like we have to first go for the MI protocol, and also if we see changes in the leads and Takotsubo, it will not be limited to one specific vessel or typical pattern that we see.
What I'm trying to say, on EKG you cannot differentiate between the two of them, right?
Yes.
You say it's a diagnosis of exclusion, so you're only going to call it Takotsubo if you have 3 coronaries on cardiac end. Okay, good. Q-wave, all right. Next one on the list is what? ST segment and T-wave ST. So what can happen with ST and T? What can happen with the ST segment? So we're talking about which part?
Depression.
This part, right? Right here. Right? So it can happen what? Depressed, gets depressed again. With what? Psychonsult. Okay. So it gets depressed with what? Huh? So there can be primary changes or secondary changes. Alright? So if you have anything underlying, whether you're talking an LVH or a bundle branch block, that can also skew your repole phase. So you can have ST depression, right? LVH will give you a little bit of ST depression and going to pull on the T wave, right? Going to pull on the T wave like that. Okay? Got to be aware of that. So those are primary changes. If you have the luxury of having somebody with LVH before, and all of a sudden, this was his previous EKG, and now he comes in and he has this, should you get worried? Right, because that pseudonormalization, and this would qualify as a ST elevation, right? Especially in the setting of chest pain and stuff. So you should be aware of that. Of course, ST depression has secondary changes to ischemia, right? So you should see that. Can you predict like the location or anatomy of a lesion based on STT depression or T-wave inversion? No, not really. All right, so it's not as good as seeing an ST elevation. ST elevation will point out to your lesion, all right? And quickly to run through that, you have your what? You have, now let's talk about STEMI, right? ST elevation. You're going to have what? ST elevation, how does it look? Well, it looks like this, right? It looks convex, right? Tombstone. Incongruent, or one next to the other, like leads, right? So if it's an inferior MI, where am I going to see the STEMI? Which leads? 2-3 AVF. And the lesion should be where? Inferior. So let's draw another card. And we'll draw the aorta with the cusps. And this is RCA, left main, left anterior, and circ. Okay? LAD, left main, left circ, RCA. Okay? And this will wrap around, we'll give you a PDA right here. This will go around here too. Okay? So the lesion is RCA, right? All right. So if it's anterior, or separate.
B1. B1 to B4.
C1 to B4. Right? Okay. If it's lateral, all right. B5 is 6, right? 1 in AVL. And if it's both, these two. So B1 to B6, 1 AVL. What is it? Left main, right? Left main. It's high, right here. Alright? And sometimes you have a combination 2-3 AVF, B5 and B6, 1 in AVL. And that will make for a wraparound circ. Usually, sometimes the circ comes down and does the inferior wall as well. So favor and give you some supply. Okay? So that's one. So what about T waves? So that's one way to predict where the lesion is. Okay? T waves, well, I guess for this session would be good enough to just address the changes that you see with hypertonia. Let's just talk about that, all right? And we'll keep the rest for some other session. So with hyperkalemia, because everybody should be aware of that, you have a T wave that the first change that happens is what? Tall and symmetric. All right? And then the whole complex, once you don't address it, starts to widen up and flatten. All right? So P wave will get flattened. All right? QRS gets prolonged, T wave gets prolonged, so you end up without a P, and this is going to be a Q wave, this is going to be a T wave, and after all, you end up with this, which is called sine wave. Okay? And the treatment for hypokalemia is what? Push the potassium in the cell with insulin and dextrose and albuterol, and for the long run, you give them Caxlate, let them pump the extra. Okay? And once you have the EKG changes, you should address it immediately, all right? Calcium, gluconate, and sodium bicarbonate. Okay? And I think that's good enough for today, all right? Like a short review of EKG.